Okay, so this is pre-hospital care of exertional heat stroke, cool first, transport second. My name is John Jardine. I'm an attending at Our Lady of Fatima Hospital. I was a EMT and paramedic in New York several years back. Been board certified ER physician for 20-something years. Been the medical director of the Falmouth Road Race since 2002, and we'll talk a lot about the Falmouth Road Race. The background behind me now is the finish line at the road race. I've done some sports medicine stuff here in Massachusetts, where I live, and I'm the chief medical officer for the Korey Stringer Institute at UConn. Let me just check this. Okay. So this is Korey Stringer. Korey was a lineman for the Minnesota Vikings back in August of 2001. He succumbed to heat stroke. He showed up to practice on the first day and he collapsed during practice, came back the second day, collapsed the second time, and ended up dying from exertional heat stroke. He was at the training camp in Minnesota, and it was so hot in Minnesota at that time that the farmers were advised to keep their livestock inside because it was so hot outside. And what happened was, Korey's family, brought a lawsuit against the NFL. The NFL settled with, his family, and the family gave the money to the University of Connecticut to form the Korey Stringer Institute so that this would never happen again. So, and the unfortunate thing is over the past year or so with, between COVID and sports changing, seasons and things like that, there've been, probably about 13 deaths in high school kids over the past year. So this is still happening. It is still a problem, and it is still something that we all need to talk about. And that's why I tend to do this lecture once a year, because now we are coming into summer, and this is the perfect time to start looking at this stuff. So my lessons are from the road. Again, I've been the medical director of the Falmouth Road Race for the past 20 years, and we'll talk about that a lot. I've been at the Boston Marathon in the finish line 10 at the Boston Marathon, a race called the Run to Remember, which is also in Boston on Memorial Day weekend, the Marine Corps Marathon, which is in Washington, D.C. in October. And as I said, I'm the chief medical officer for KSI. So some of the other things that I've done over the years, and again, just to sort of show how, what happens clinically gets put into policy. I've been asked to be an expert witness on some legal cases involving kids who have died from heat stroke or suffered problems from heat stroke. I was invited to the United States military, Marines, Navy, and Air Force, Marine Corps marathon protocols, and then they have become now the International Institute of Race Medicine protocol. So I was invited to sit on that board to write the international protocols. IAAF, which is now World Athletics, in 2019 had the World Championships in Qatar in the Mideast, and where the average temperature is about 130 every day. And we were invited to do some work there as well. If anybody follows track and field or followed that event, you know that they started the marathon at midnight because it was cooler. It was only about 90 degrees at midnight. And they also, for the first time ever, had a loop track so that they could keep track of all of the runners at the same time. So that was in 2019. Tokyo Olympics 2020, which turned out to be 2021. I was involved in reviewing the protocols for the Tokyo Olympics because it was set to be and actually was the hottest Olympics on record. And then over at KSI over at UConn, we worked with the United States women's national soccer team to get them ready to go to Tokyo. So we did some heat acclimatization stuff for them in the lab. So what we're going to talk about tonight is temperature regulation and the heat illnesses. How does people get in trouble with heat illness? We're going to define exertional heat illness, most specifically exertional heat stroke. We're going to talk about the treatment of exertional heat stroke, our role as EMS in the treatment of heat-related disease, and present a new paradigm for the pre-hospital care of exertional heat stroke. So the first thing, for those of us who have been EMS for a while, the EMS conundrum is, when we pick up a patient, is it a scoop and run situation or is it a stay and play thing? So is this something that has to get to the hospital urgently, or is this something that, we can take some time? And certainly there are a couple of diagnoses that are, time dependent. Certainly an ST elevation MI, we'd say that, heart muscle is time, right? So the longer we delay, the more damage to the heart. So that's a timely diagnosis. And now stroke too. We know that, time is brain as well, right? So our goal is to get somebody to a stroke center quickly. So I would also say that exertional heat stroke is a diagnosis that requires timely intervention. This was a study that was done back in the 70s. It was done with rats, and they heated up rats and they showed, just how long it would take for them to succumb to the heat. And you can see after about 30 minutes that survival drops off precipitously. So you really have, we figure about 30 minutes to enact some good treatment for exertional heat stroke to make a difference. So again, I think that exertional heat stroke is a timely diagnosis, something that needs to be made right away, and treatment needs to start right away. So I'm going to present two different scenarios of exertional heat stroke, one in which you're prepared for it, in other words, at a road race or other outdoor activity, and then one is more emergent and, just comes upon, as a call or you come upon the scene where it's occurring. So first, late August, if you look into the southwestern sky, you see this constellation. This is the Dog constellation, and Sirius is the brightest star there, and Sirius is the Dog star. And the reason that I mention that is that even as far back as 3000 BC, when people saw the Dog star in the sky, they knew that these were the dog days of summer, right? So this is where that term, the dog days of summer, comes from, because Sirius is in the sky. And they noticed that, during the dog days of summer, that people were, Sirius brought fever in men and madness in dogs. And it was actually, they termed a medical term called Siriasis, named after Sirius the star, for all times the heat illness that was occurring. And that persisted well into the 20th century until we learned a little more about it. Fast forward a couple thousand years, and the Falmouth Road Race was established in 1973. The race this year will celebrate its 50th running. It's a 7-mile race. It's held the third Sunday in August. Why 7 miles? 7 miles is because it started from one bar to another bar. And that's why it's a sort of a peculiar race at 7 miles. We registered 12,800 runners. Of course, the spectators number far greater than that, and all the medical care at the road race is provided by volunteers. This is the start of the race. If anybody has been to Falmouth, Massachusetts on the Cape, this is Woods Hole, and you can see there are about close to 13,000 people ready to start running the Falmouth Road Race. And we published this back in 2018. This is about the organization of a medical team. This is how, if you do have an event that you want to prepare for, how you start preparing. You have to have sort of everybody on board, EMS, police, fire, the local hospital, et cetera. And then you have to, assemble a medical team. And we have about 200 people on our medical team. We have 5 different medical stations, and we have, like I said, roughly 200 people. And you have to provide training, right? So everybody has to be on the same page. You have to know the protocols for the day, what to expect, et cetera. So you develop a training program for the day. And then you position yourself in a place where you can do the most good. And this is the big white tent there that you see is at the finish line of the road race. I noticed that people are raising their hand, and I'm sorry, I'm not savvy enough to do both, look at the chats and do this. So if you can wait till the end, hopefully we can answer questions at the end. Okay, thanks. So what we work out with the team is 6 different, we call them the 6 H's that are going to cause somebody to collapse. So what's going to cause somebody to have a problem at the end of the race or collapse during the race? And these are the 6 H's. Heat, of course, heat illness is what we're talking about tonight. Heart, if it's a cardiac issue. Hyponatremia or low sodium. hypoglycemia or low blood sugar, and then hemoglobin for sickling, like people with sickle cell trait or sickle cell disease, and of course head injury, which hopefully doesn't happen in a road race. The other thing is, because we are EMS folks, we add that seventh H for the the holy crap stuff, the stuff that you really don't expect, but you have to prepare for. So we have lots of medical stuff on site for whatever could and will happen. So let's talk about temperature regulation. So body temperature, core body temperature, is dependent on the balance between heat production from metabolism and the heat loss to the environment. So it's just a balance of what you're creating and what then has to be dissipated to the environment. Now, certainly if it's hot outside or you have environmental heat stress, that may increase the need for heat removal, and that just kind of makes sense, right? So temperature regulation, heat production during intense exercise is 15 to 20 times greater than at rest, and can raise the body temperature almost 2 degrees every 5 minutes if we don't remove that extra heat. So, you're working outside, you're running, whatever the activity is you're doing, you're generating almost 2 degrees body temperature every 5 minutes. So we need a way to get rid of that heat so that we don't overheat. And we do that. We have a physiologic response to heat, and what happens is you sweat, right? Anybody who's been outside or been active outside, that you start to sweat. Blood diverts away from the inner organs out to the periphery, and what happens is, as you sweat, the sweat evaporates, it cools the blood underneath, and that's our mechanism to how we respond to heat and how we cool the body. The problem is if you get into a situation where the metabolic heat you're producing outpaces the ability to transfer heat to the surroundings, then the core temperature rises. So, say it's very humid outside and you can't sweat, or the sweat is not effective, or, in cases of occupational or your military, you're wearing special clothing that, you can't get rid of the heat. So this is where we run into problems, is when you can't dissipate that heat. And what happens is it causes an injury. It's an acute phase response, just like sepsis, which eventually can lead to end organ damage and death. So it's a cascade that happens similar to sepsis. So one of the heat in illnesses that you may see is heat cramps. And this has been renamed exercise-associated muscle cramps, because it's been found that it actually isn't caused by the heat. But certainly in these activities where you are sweating and you're replacing your losses with hypotonic fluids, and your electrolytes get out of whack a little bit, it certainly puts you at a higher risk. But exercise-associated muscle cramps is just painful cramps in the large muscles of the limbs and sometimes the abdominal wall. How to treat these? Of course, get out of the hot environment, get into a cooler environment. General static stretching. We find that if you stretch the muscles, it helps a lot. Some of the people that we have in medical tent are physical therapists and chiropractors and stuff for stretching. You can replace the fluid and salt that you're losing when you're sweating, either orally or by IV. And you may start to worry about hyponatremia if you have protracted cramping. Excuse me. Because Falmouth is a short race, we typically don't see hyponatremia. That's typically in events that are 4 hours or more. So certainly in marathons is when you see things like hyponatremia. So heat exhaustion is the most common thing that you're going to see. It's the most common heat illness, and it's simply defined as the inability to continue exercise in the heat. And what happens is you have a fluid depletion problem. So you don't have the cardiovascular compensation that's needed to sort of help you feel better. So the easy solution is to give fluids, and the signs and symptoms vanish. So that's the good thing about heat exhaustion. The symptoms pretty non-specific. People are dizzy, they're weak, lightheaded, they may be nauseous, maybe vomiting, sometimes have a headache, just feel miserable, right? So this is the non-specific symptoms of heat exhaustion. The important thing to remember, though, is that mental status remains normal. So these people have a normal mental status, normal cognition, etc. And of course, they're sweating a lot because they've been active in the heat. Now, heat stroke is a life-threatening emergency. And this is defined as a high temperature, and you see the temperature there, 104.5 or more, with CNS dysfunction. So two things you need for heat stroke is you need a high temperature and you need altered mental status by whatever means, unresponsive or combative, etc. Just an altered mental status. These people look awful. Their skin is ashen. They lose what we call hind limb function. And typically these are the people that collapse either after or during a race. So this is heat stroke. So this is a pathophysiology for heat stroke. As I told you, it's very similar to a sepsis-like condition. It's an acute phase response where you get just a sort of a cascade of things that start to happen, even after the heat illness is gone, even just like sepsis after the infection is gone, you still have this overwhelming response that sort of cascades and can cause end organ failure or even death. And it affects every organ. Certainly the central nervous system is affected first, the cerebellum in particular.
Headphones in, what?
Can you mute yourself, please? So, so central nervous system is affected first, but of course, all organ systems are affected, just as with sepsis. So this is exertional heat stroke. And this guy down in the corner here, this is Hunter Knighton. He played for the University of Miami. He suffered a heat stroke and survived. He now goes around speaking about heat stroke and the treatment of heat stroke. And he reminds us that people think about typical heat stroke as classic heat stroke, and there's a difference between this and exertional heat stroke. Can I remind everybody to mute themselves, please? There's some background noise. Thank you. So again, heat stroke, classic versus exertional. Classic is probably what we've all learned about or certainly have heard about. And this is the people, old people that are stuck in their apartment in the heat and or kids that are locked in a car or something like that. And these are the patients that present with hot, dry skin. And if you read about heat stroke and you say, well, you lose the ability to sweat and the skin is hot and dry, that's classic heat stroke for sure. But in exertional heat stroke, because patients have been exerting themselves and because of the activity, there's going to be profuse sweating. So there is sweating with exertional heat stroke. It's not the hot, dry skin with classic. And this, again, occurs in physically active people. So runners, athletes, firefighters, soldiers, there's a big occupational hazard right now with people working outside in the heat, et cetera. So this can happen there as well. So again, I'm talking about runners. We're talking about my experience with road races, et cetera, but it's all active population. So other athletes, other athletic events, again, people who are working outside in the heat are at risk. Our military, depending on where they are certainly at risk as well. So it's not something that's just going to happen in road races. So again, firefighter in a wildland fire, migrant workers, construction laborers, and again, some of the medical legal cases that I've been involved in involve occupational settings. So again, I told you that the definition of heat stroke is two things: a change in mental status and a high temperature. So do we need an accurate temperature? That's always the question, right? Well, I'm going to say yes, because we need to determine if it is or isn't exertional heat stroke. So if it's not, is it heat exhaustion? Is it a head injury that's causing an altered mental status? Is it hyponatremia, a low blood sodium? Is it a low blood glucose issue? Or is it just something else? So we do need a temperature. If you look at the differential diagnosis, this differential diagnosis chart, and you look across the top, those are some of the 6 H's that we talked about. And the only one that has an elevated body temperature is exertional heat stroke. So again, to rule out all the other things, we do need an accurate body temperature. So the other reason that we need a temperature is to determine when we stop cooling. And we'll talk about cooling and when we stop and things like that in just a few minutes, and to determine if an actual exertional heat stroke has occurred, because we need to then develop a plan for getting people back to activity or back to sports or whatever it may be. So if they have had an exertional heat stroke, then that becomes very important when we plan getting them back into activity. So we have lots of options for assessing body temperature, right? Lots of ways to take a temperature: axillary, oral, tympanic, temporal. You can see some of the others there, esophageal, rectal. So lots of ways to take a temperature. So what we, when we look at these different means to take a temperature, we look at what's valid. We need a valid temperature, but we also need something that's logistically feasible, right? We need something that we can do quite easily, especially in the field, right? So if you look at what's valid is esophageal temperatures, urinary bladder temperatures, pulmonary artery temperatures. Obviously it's not something that we can do feasibly in the field. But if you do look at what's feasible, oral, meaning the ear, canal, temporal, axillary, the one that fits both categories is rectal. So rectal temperature is necessary for assessment of core body temperature. So if you look at rectal versus axillary, clearly axillary is not accurate enough. It can be off by 6 or 7 degrees. So certainly not a substitute for a core body temperature. If you look at oral, same thing, can be off by 3, 4, 5 degrees. So not a substitute. Tympanic, forget it. Another 4 degrees or so off. We did a study in Falmouth in 2019 that every exertional heat stroke that we treated, and we used rectal thermistors, everybody who had a rectal thermistor had an infrared tympanic temperature taken at the same time. And you can see that if you relied on a tympanic temperature, that you would have missed all but about 2 heat strokes. So tympanic is not an accurate way of measuring temperature. And temporal, forget it. That's the, swipe across the forehead thing, forget temporal. That's another 4, 5, 6, 7 degrees off. Certainly not an accurate way to get core body temperature. So the problem is asking people to do a rectal temperature, and certainly it is not a comfortable thing to do or to ask people to do. And there are certainly some sort of negative connotation about it, but it is the most accurate way of getting a core body temperature. So let's go back into history again. In the 1880s, this is a trade magazine for farmers. And they were talking about sunstroke. They called it sunstroke, but the treatment is summed up in 3 words: reduce the temperature. So again, even back in the 1800s, they knew, obviously, you had to reduce the temperature. And it went on to say that, the person should be removed to a shady place, and his whole body, especially his head and chest, deluged with ice water. So again, back in the 1880s, they kind of knew how to treat exertional heat stroke. So this is not something groundbreaking. There have been lots of studies on different ways to cool people, but what has emerged as the gold standard, this was published in 2007, is cold water immersion as the gold standard for exertional heat stroke treatment. And the key to maximize the chances of surviving an exertional heat stroke is rapidly decreasing the elevated core body temperature. Just what they said back in the 1880s as well. So we know that we have to get the temperature down, and cold water immersion is the best way to do it. They've looked at different cooling modalities. You can see ice packs over the arteries and various things, including right in the middle there, helicopter downdraft, where they use the spinning blades of the helicopter to cool people off with a breeze. But clearly what has stood out is cold water or ice water immersion as the best way to cool someone, the quickest way to cool someone. And again, the gold standard. So for that reason, the American College of Sports Medicine, our United States military, the IAAF, now known as World Athletics, and National Athletic Trainers Association all advocate the use of ice or cold water immersion. So all of these people are saying that this is the way to do it, and certainly is the gold standard and the way to do it. So this is a picture of a tub at Falmouth. This is a Rubbermaid stock tub. This is a 50-gallon tub and filled with ice and water. And it's just clearly as simple as that. So this is our finish line medical tent in Falmouth. We have lots of tubs set up because we tend to see a lot of exertional heat stroke at the race in August. So what about the other places or other lessons from the road? Certainly, this is the Boston Marathon. If anybody has volunteered at the Boston Marathon, the morning of the marathon, as the marathon is starting, there is a medical conference for all the volunteers that are volunteering in the finish line tents. And you can see that slide there that they're showing is the slide that I just showed. Again, in Boston, they're saying that cold water immersion is the gold standard. The picture down to the right is a very small picture, but that's a picture of somebody in an ice immersion tub at Falmouth, actually. So even Boston uses Falmouth as their sort of education. This is the Boston Marathon. This is the A tent at the finish line of the Boston Marathon. And you can see that they have tubs set up there in the heat deck for cold water immersion. Now, the Boston Marathon is in April, as you probably know. So in April 2012, I was there and it was 95 degrees. In April 2018, I was there and it was 30 degrees. So you never know what is going to happen in August or April in Boston. This is the run to remember. This is a run in Boston as well. This is during Memorial Day weekend, and you can see that, if you can tell on the, it finishes indoors. It finishes in the seaport, and again, cold water immersion used there. This is the Marine Corps Marathon, October, Washington, D.C. Can still be warm down there. And again, they use cold water immersion at the Marine Corps Marathon. And then just play other places. New York City Marathon up to the top left. That's in the first weekend of November, but you can still have some warm temperatures there. Japan in the bottom, that's when they were experimenting and preparing for the Olympics. The Netherlands, we had people from the Netherlands come to Falmouth and spend time with us in Falmouth, and then they brought back the idea of cold water immersion to the Netherlands for their Amsterdam Marathon. And then, of course, Tokyo 2020, actually 2021, where they used cold water immersion for what was now known to be the hottest Olympics on record, and they used that for the athletes there. So this is the tub, and I don't get any kickback from Rubbermaid or Tractor Supply, but this is Tractor Supply company selling the tubs. It's a stock tub for feeding livestock, and this is a 100-gallon tub. Like I said, we used a 50-gallon tub at Falmouth, but that's that's where you would get a tub if you're interested or looking. What are some misconceptions about the tub? If you've been in emergency medicine for a while, and some of the old timers will tell you, like, oh, you can't throw somebody in ice water, they'll vasoconstrict and they'll start shivering and they'll start storing heat and their body temperature will go up. And that's not the way to do it. That's partially true. This is called the Korey response. If you look at the graph on the left, if you threw one of us right now, who should all, I guess we're all normothermic. I don't know where you're sitting, but if you're normothermic and somebody threw you in an ice tub, yes, you would start to shiver. Yes, you would vasoconstrict, and your temperature would go up just a slight little bit before it started to go down. And you can see it's not even a half a degree that you would, again, yes, it's true. You vasoconstrict and shiver, and then you start to warm up before you start to cool off. Contrast that with the people in the right side, 43 degrees Celsius, 109 or so rectally, there is no shivering and there is no vasoconstriction. It's all cooling when you put somebody in a tub. So there is no concern for vasoconstriction or shivering. Cardiovascular shock, they say, well, if you put somebody in, dunk somebody in cold ice water, their heart's going to stop. Again, in my 20 years, 400 patients of doing it, I've never seen anything even close to that. Cannot administer other care. I will show you what somebody looks like in a tub, and I'll show you that you can certainly administer other care to patients. And after drop is something that we deal with. Occasionally when people are cooled off, they continue to cool even when you take them out of the tub and their temperature continues to go down, and they may actually get a little chilly. But they're not going to die from that, and certainly they can die from exertional heat stroke. So it's something that we deal with very occasionally. This is a mesh stretcher, and we use this for picking up hot, sweaty athletes, right? Instead of trying to muscle them up, we put them on this mesh stretcher. We can pick them up and put them right into the ice water with that. So that is extremely helpful in moving people around and getting them in and out of the tubs. This is what someone looks like in a tub, and you can see that you have full access to their arms, legs, head. If you have to take blood pressures or do whatever you have to do, typically you have good access. And this is why we prefer to use the 50-gallon tub in Falmouth, is that we can still, have good access to the patients and we don't lose them in a big tub of water. The other thing is it's a team event, right? There's lots of help around. There's lots of folks that are going to be helping. Again, we, have a lot of medical volunteers that help, and certainly you're not going to lose somebody in a tub. This is a patient who did come in who was unresponsive. He came in, he collapsed at the finish line. His rectal temperature was 109. He was unresponsive when he got into the tub. So we did have to support his head to keep him out of the ice water from going under. But again, this is what we do, and this is a team event, and there's lots of help. This guy eventually cooled off and was discharged from the tent and went home with his family. So, we'll talk about our disposition in a minute, but he did fine. So what is our protocol in Falmouth? Just to kind of share what we do there. Patients come into the tent. If they're brought into the tent for any reason, they all get a rectal temperature. And that's the way that we assess core body temperature. If they have a temperature greater than 104 and they have a change in mental status, they go to a treatment team with an ice water immersion tub. So patients are then immersed in tubs half filled with ice water, as I showed you. It looks something like this. This is a patient in a tub, and then we use cold towels to kind of, help circulate the water, et cetera, and cover as much body surface area as we can. So it looks something like that. Vigorous massage is applied. We have to keep the water kind of circulating because when you put somebody who's 109 into an ice bath, they actually melt the ice. And the water nearest their body actually starts to heat up. So you got to keep the water circulating. You got to keep the ice and water circulating, and keep, again, cover as much body surface area as we can with wet towels, etc. Rectal temperatures are taken every 5 minutes or continuously monitored. We choose to continuously monitor. We use a rectal thermistor. Once we determine that someone has heat stroke, they have a thermistor that's inserted, and it stays there for their entire stay in the tent. And you can see here, this is the thermistor. It shows this person is at 105. So we can watch their temperature. We know how fast they're cooling, etc. And then when their temperature reaches 102, and again, we're continuously watching it with the thermistor, or they've been in the tub for about 20 minutes is usually all it takes. They are removed from the tub, and then they're brought to a sort of a recovery area. We watch them for anywhere from 20 to 60 minutes, depending on what's going on. They keep the thermistor in until we are ready to discharge them. So we continue to monitor their temperature. Very occasionally, some people go back up after getting out of the tub, and then they have to go back in. Certainly, if they're normothermic, their temperature returns to normal. They have normal vital signs. They're cognitively okay. They're taking oral fluids. We will discharge them from the tent with family or a friend. And we do have discharge instructions, etc. We're comfortable with this plan because we've done it for such a long time. If you volunteered another race or have a race of your own, for instance, Boston, they send everybody to the hospital no matter what. So we are a little more comfortable with what we do, and we have a small group, so we are able to discharge people from the tent. Very rarely we have to send somebody to the ER for further evaluation and treatment, and I'll show you some of those stats. So this is this is my time as medical director. We've collecting data over the years, and you can see that these are the heat strokes by year. And this is the percentage of people that we have sent to the hospital. That lighter blue is people that have gone to the hospital. And you can see, again, 90% of our patients are discharged directly from the tent. And again, this is, with a family or friend, discharge instructions, et cetera. And again, we're comfortable with this plan because we've done it. We have the same people working there, year after year, and we kind of are very familiar with this. So, but again, it's something that can be done to discharge directly from the site. So in 2014, we published this article. We looked at the effectiveness of what we were actually doing. So, the cold water immersion at Falmouth, and we looked at that time in 2014, there were 274 cases. We went back beyond when I was there as medical director. So we were able to gather a few cases from the past. And then of course, what we have collected since, and we can see that we have about 2 cases of heat stroke per 1,000 finishers. So again, if you remember that we registered 12,800. You can roughly, we're going to see about 20 a year. And you saw from the graph that that can be up or down depending, on the weather conditions that day. We looked at males versus females, real hot body temperatures versus not so hot body temperatures, and there was really no difference in cooling. We looked at different age groups. There was really no difference in age groups in cooling. So again, if you look back at my time as medical director, I've seen now 403 cases of exertional heat stroke over the 20 years. We had about 91 cases that we were able to pull from previous. And the point of all this is that it's 100% survivable, right? So if you treat exertional heat stroke with cold water immersion within 30 minutes or so, then it is 100% survivable and should be so. So back to the EMS conundrum, again, scoop and run versus stay and play. We know that this is always the debate when we pick somebody up or find somebody. So the question comes up, can we do this in the ED, right? So this is where I work. This is Our Lady of Fatima. This is one of the typical rooms in a community hospital. Can we cool somebody in this setting? So certainly if you're in Falmouth on race day, you can cool somebody in the ER because we have tubs set up in the ER on race day, just in case somebody gets by our medical program there and they get to the ER instead. So yeah, so on race day, you can get cooled in the ER, but how many of us have these tubs set up, on any random day in the summer? We don't, right? So how are we going to do this in the ER? The other thing is, temperature measurement. This is the temporal thermometer that I talked about. And this is, usually the way that we ascertain temperatures initially, in the ER. It's a quick and easy way, but very inaccurate, right? So it is not going to be accurate for diagnosing, excuse me, exertional heat stroke. So we're going to have to, make a better effort to get rectal temperatures for core temperature measurement. Now, we were all taught too, when somebody's hot, right, to get cold packs, get your ice packs and put them in the along the major arteries, right? Put them in the armpits, in the groin, in the neck, next to all the major arteries. So this was a meta-analysis study done in 2009. They looked at all various kinds of cooling rates by different modalities, cooling modalities, and decided what was acceptable and what was not acceptable for cooling. If you look at ice packs over the major arteries, not really an acceptable way to cool somebody. It's not going to work in the 30 minutes that we're talking about, and it's going to take too long to cool somebody down, and it's not an effective way of cooling. So let's look around the ER. What else do we have? Well, we have these cooling blankets, and this is a blanket with channels in it that this machine on the right will then pump cold water through the blanket. You put the blanket under the patient and the cold water gets pumped through. What about this as a way to cool somebody? That can certainly cool somebody off. Well, barely makes a blip on our graph here, right? So this is clearly an unacceptable way to cool somebody. Never going to cool somebody quickly enough using a cooling blanket. So not acceptable. How about cold IV fluids, right? So if we keep a couple of bags of IV fluid in the refrigerator, and then when somebody like this comes in, we can start an IV and we can give them cold fluids. How about that? That's not going to happen either. They did a study that, they started IVs in the wrist and then measured the temperature up in the shoulder. And they found that by the time the fluid got from the wrist to the shoulder, it was already warmed to body temperature or above. So cold IV fluids not going to work for cooling somebody with exertional heat stroke. What about rotating cold towels? Just simply taking towels and dipping them in cold ice water and rotating them out as they get warm. And this is actually an effective way of cooling somebody. So this is a good way. It's a good way to start, certainly. If you're on a scene and there's a cooler of ice water and you have towels, just start dipping the towels in and start rotating cold towels. This is actually an acceptable way of cooling somebody. But I ask you to think outside the box, right? Think about tacos. And this is the taco method. This is the TARP assisted cooling method, or the taco method. And really what it is putting somebody in a waterproof tarp pouring in a bucket of water, pouring in a bucket of ice, and just kind of sloshing them around in the tarp like they're in a taco. So again, this is a very effective way of cooling somebody, and it's an effective cooling rate. And if you say, well, we can't carry a big tub around, well, you can probably carry a tarp around. So the tarp, water, and ice, and you have the taco method. So I kind of looked around the ER and I said, well, we have these, death shrouds, right? The postmortem kit, the impervious shroud, the body bag, whatever you want to call it. And these are impervious, these are waterproof. And if you open up a body bag, it looks like a burrito, right? So this could be we have the taco method, this could be the burrito method. And certainly we've used this and it's been used. The cooling method is absolutely effective. Again, it's like putting somebody in the tarp or in a tub, and it's been used and reported. So this is September 2019, and this is a report out of California where they used a body bag to save a woman from heat stroke. And this is a woman came into the ER with heat stroke. They put her in the body bag, ice and water, and cooled her down. This was in the press last year. This is July 2021. ERs using body bags to save lives. And I can tell you, from our experience, I've used it twice myself last year in Fatima. And I know some of my colleagues have used it as well. So it is an effective way, and it prevents a lot of mess. One of the problems, though, one of the biggest problems is this is my ice machine, right? So I am going to need a lot of ice, and this may not be able to keep up. So, you have to be resourceful and think about where you're going to get that much ice. Certainly the cafeteria of the hospital, but then you have to, think, is the cafeteria open? Is there somebody available? Is the ice machine working? Things like that. So you kind of have to have a plan for where the ice is coming from, certainly. So I take you back to this study again, and again, we have about 30 minutes, to act to increase survival, certainly. So it is a timely diagnosis. And they looked at this again as well in 2012 and said, not only is this, something that we can do to cool people, but maybe we should cool them first and transport second. And they came up with this sort of mantra: cool first, transport second. And that's essentially what it means, is to cool somebody before thinking about transport. So here's a case that sort of proves that. This is a tale of two heat strokes. This is done by a colleague of mine at KSI. This is two people who were running the Marine Corps Marathon, and two people who had exertional heat stroke. The one on the left, the round black dots, is a patient who finished the race. He collapsed at the finish line. He was brought immediately to the treatment tent at the finish line. Rectal temperature was done. He was diagnosed with exertional heat stroke, and he was cooled in an ice water immersion tub. And you can see that after about 30 minutes, his temperature is down, and he did fine. The second patient on the right, the gray boxes, this is a patient who collapsed at mile 24 of the marathon, was taken off the course in an ambulance. The ambulance brought him to a hospital. In the hospital ER, you can see that it took more than 60 minutes for them to even get a temperature. So the first temperature wasn't taken until about an hour later. And then they cooled him with ice packs in the groin and axilla, et cetera, et cetera. And you can see how long it took him to cool. And he ended up with both kidney and liver failure. He was on the liver transplant list for a while, but actually recovered from the illness. But you can see the difference in the way that you treat two heat strokes, right? And the prompt treatment is certainly better for the patient. This is another great case. This is a kid named Gavin Class. Gavin played football for the University of Towson. He was at training camp in the summer. He had an exertional heat stroke, which was recognized and diagnosed by the athletic trainer. They brought him to the sideline. They put him in the shade. They put him in an ice water immersion tub, and they called 911. Firehouse right across the street. The ambulance gets there within 5 minutes. And what happens? They pull him out of the tub. They said, oh, no, he has to go to the hospital. He arrives at the hospital with a rectal temperature of 109. He has had 21 surgeries, including a liver transplant. He had kidney failure, liver failure, et cetera, and ended up with a liver transplant. He survived. He works as a strength and conditioning coach now in Colorado, but he obviously can no longer play football. But again, this shows you the, what should or could have happened if he stayed in the tub. So we all know that EMS is protocol driven. We, have to follow protocols. Everything is sort of spelled out for us, if you will. So imagine, a few years ago in Rhode Island, when we're talking about cardiac arrest, they came up with a new protocol that said, for people in cardiac arrest, we're going to stay on the scene for 30 minutes. We're going to do CPR on the scene for 30 minutes before we even start to transport somebody to the hospital. Now, when I first heard that, I thought that's the craziest thing I've ever heard. Where's the science behind this? And certainly there is science behind this. This is a study that was done in Japan, and it was done with, like 10,000 patients or something. And they showed that if you stayed on scene for anywhere between 30 to 42 minutes, that recovery was actually better and people were walking out of the hospital. So they showed that, if you stay on scene and treat somebody on the scene, they will do better than if you rush them to the hospital. And certainly it worked, right? In North Carolina, they showed that, there were people walking out of the hospital after cardiac arrest, because what these people needed was chest compressions and maybe an AED or something that they needed treatment immediately. And, it didn't have to necessarily come from the hospital. So what came out of that is a new protocol in Rhode Island. For those of you in Rhode Island, and you know that when you find somebody in cardiac arrest, you stay on the scene for at least 30 minutes to do good, high quality CPR and then think about transporting somebody. So here is, a severe, or probably the most severe diagnosis, right? Cardiac arrest, and we're waiting on scene to do our treatment before we transport. So, is this something that we can do with exertional heat stroke? It is, and it is something that we have done. This is Connecticut's protocol, the first of its kind, where we said if you have exertional heat stroke, you'll take a rectal temperature on scene and you'll diagnose exertional heat stroke, and then you'll stay on the scene and cool somebody until their temperature comes down to 102. Additionally, it protects people like Gavin Class, who, if you come on a scene and there is cooling underway by a medical person, you are to stay there until their temperature comes down to 102 before you transport. So this is a cool first and transport second protocol. There are some states that are sort of falling into place as well. This is Maryland. And although they don't have, the diagnosis by rectal temperature, they do say that if you come on a scene and somebody is cooling, that you are to stay on scene and continue cooling until 102 before transporting. So cool first, transport second. Massachusetts, not so good. They have since, added that if somebody is being cooled, you're to stay on the scene. But, we went to the office of EMS in March. We proposed a new protocol for Massachusetts, and they are still sort of working out the language because they don't know how to mandate something like cold water immersion. So, they're having problems with wording. So again, it's in the works. Rhode Island, not too bad. But again, the cool first, transport second thing should be a part of the protocol. So in 2018, we got a bunch of ER doctors together and we published this consensus statement. It was published in Pre-Hospital Emergency Care for pre-hospital care of exertional heat stroke. And what it did was present a new paradigm for EMS, for the care of exertional heat stroke, and really just 4 steps, right? So rapid recognition, rapid assessment, rapid cooling, and then rapid advanced care. So if we can use that as a means of summary, recognition, again, 2 things, hot temperature and a change in mental status, temperature greater than 104 is what we use in Falmouth, and an altered mental status. And then you recognize exertional heat stroke. Assessment, I talked about the importance of rectal temperature. I understand sort of the negative aspects of it. And believe me, that is the biggest hurdle right now, is to get people to accept doing rectal temperatures. But rectal temperature is the most valid and feasible way to get a measurement of core body temperature. Rapid cooling, cold water immersion clearly is better than anything as far as cooling rates to get somebody under, the threshold temperature within 30 minutes. And then again, remembering to choose the proper cooling, and then cool first, transport second, remembering to cool somebody or allowing somebody to be cooled before initiating transport. So for me, the EMS conundrum is, in this case, is sort of solved, right? This is a stay and play diagnosis. This is something that we need to stay on scene and treat on scene before transporting, because we can do a heck of a lot more good in that 30-minute window if we stay on scene than trying to transport somebody to an ER where it may or may not happen. We are innovators in EMS. These are some pictures out of Austin, Texas. This is you can tell is a shopping cart with a tarp in it with ice water in it. So this is their way of, innovating some ice water immersion for somebody with heat stroke. They also have these pictures of, these are one of these people mover things and a tarp in there, and they just poured ice and ice water in and to attempt to cool during transport. So again, we can, we are innovators. We can work on the fly and certainly make a difference with this kind of stuff. Because I can't do this in there, right? I can't adequately cool somebody like we can on scene, certainly in the ER. So cool first, transport second. That's the mantra to remember, and the sort of the take-home message of this lecture. You can visit the KSI website, ksi.uconn.edu. There's lots of information there, including this video. This video was sponsored by the NFL. We filmed it at Gillette Stadium. It's an actual, it's a representation of somebody collapsing and then being brought to the tub and then eventually transported in the ambulance. And it's about a 12-minute video. And if you've never seen somebody treated for exertional heat stroke, it's well done. It's pretty good. You can certainly follow us on social media as well. So this is my email. If anybody wants to email, if you have other questions or concerns, you can certainly email me, and that will wrap it up. And I will open up for questions now. Let me just check the chat box real quick. Looks like just people signing in. So if anybody has any questions, please, you can, feel free to unmute yourself, or if you want to put it in chat, either way. Anybody have any questions?
Thank you for the lecture. I just was curious, could you send a link or the title again of that video that you mentioned? Oh, the 12-minute video.
Yeah, if you go to ksi.uconn.edu, that's the website for KSI, and you'll find it on that website. It's a educational video. Again, it was sponsored by NFL.
Having a skeleton is going to assist him. And he actually advanced higher.
Thank you.
You're welcome.
So I did hear that they.
Somebody has their microphone on. I'm not sure if you want us to hear what you're talking about.
Oh, I heard part-time.
Anyone else with questions? Again, feel free to email or reach out if you think of something afterwards.
What is Ricky? Yeah. Well, she's not.
She didn't get the call though.
She doesn't want full time.
Oh, okay. I heard that she was getting off. That's what Jody.
Well, Jody said that a while ago. And I asked Steve about it. He said, no, we don't offer any full part-time. He only wants part-time on school.
Why don't we want to offer part-time too? That is your.
So on Wednesday.
All right, I'm going to stop recording because I can hear people in the background.
Going to slice your own fucking throat.